to thank Professor Dimković and Professor Donfrid for inviting me to this meeting. I've never been to Belgrade before, but I like this town, and of course I like all the colleagues here sitting here and being so interested in vascular access. Last but not least, the treatment of deep vein thrombosis, of stenosis and occlusion of central arm and leg veins can be very problematic in hemodialysis patients. The reasons for central vein obstructions in dialysis are quite clear. Of course, some patients do have some kind of chronic fibrosing mediastinitis or lymphoma or pulmonary carcinoma causing central vein obstruction, but of course the great majority of patients suffer from central vein obstructions due to hemodialysis catheters. Once acute non-tunnel catheters are implanted into the subclavian veins and remain in place for 2 weeks or longer, we have to encounter obstruction rates of about 50%. The internal jugular vein, especially the right internal jugular vein, is not so prone to the stenotic process as long as the catheters are extracted after some time. The femoral vein is problematic. As soon as the catheter is implanted for longer than 2 weeks, we have to encounter about 30% of stenosis rates and iliacofemoral thrombosis rates. There are not so many information in the literature about central vein obstruction rates caused by tunneled, cuffed catheters. Tromboza found 0 stenosis rate in his series of right internal jugular vein catheterizations versus John, who left catheters in place for months and years. Tunneled, cuffed catheters for chronic hemodialysis found about 50% central vein obstructions, even if the right internal jugular vein was used for implantation. The consequences are quite clear. As soon as there's an arteriovenous axis functioning distally to the central vein obstruction, arm, face, and breast swelling may occur depending on the location of the stenosis or occlusion. Venous hypertension may lead to skin ulcerations. Swelling will lead to difficult cannulation, risk of bleeding and hematoma infection, and at last risking the loss of the axis. There are several therapeutic options for the treatment of central vein stenosis. Of course, radiological interventions like angioplasty and stent implantation, and some surgical alternatives. Depending on the extent and location of the stenosis, I would like to present some kind of algorithm which kind of stenosis or occlusion to treat in which way. Unilateral obstructions in many cases can be treated interventionally. Short stenosis and even short occlusions of the subclavian vein can be recanalized by guide wires or by special rotating devices like this Rotex catheter. After ballooning, these recanalized veins often have to be treated with additional stent implantation to cope with significant rest stenosis. Once central vein obstruction cannot be overcome with guide wire, of course intervention is not possible. In such cases, veno-venous bypass surgery must be considered. The extra anatomical axillary vein to internal jugular vein bypass is not very invasive and can be performed even in higher risk ASA 3 or ASA 4 patients without endangering them. In case of obstruction due to pacemaker wires, port catheters which cannot be extracted or whatsoever, ligation and contralateral axis creation should be considered. Superior vena cava obstruction in some cases can be treated interventionally. I already saw a slide like this in the morning. In this case, a web-like, very short stenosis of the superior vena cava at the venous confluence of the both innominate veins was treated by this Y-shaped stent implantation. In case of superior vena cava occlusion that cannot be recanalized interventionally, one can think about some kind of anatomical reconstruction. In this case, we had a brachiocephalic arteriovenous axis with complete occlusion of the outflow tract, and I recanalize it with a cephalic vein to superior vena cava bypass via median sternotomy. This is, of course, major vascular surgery and can only be performed in a small minority of hemodialysis access patients. Most of these patients would be treated by ligation of the arm axis and creation of a femoral axis. Femoral axis in most of the patients means implanting a femoral artery to femoral vein PTFE loop graft, but in some very thin patients, one can consider a popliteal artery to greater saphenous vein, AV fistula, which can be needled rather early after the operation when the patient is thin enough. When superior and inferior vena cava are obstructed, of course, we have a problem to construct an arteriovenous axis. In some of these patients, one might think about implanting a transhepatic catheter, but of course we all know this is only a very bad solution for this very bad problem. In low-risk patients, the right atrium can be used as the venous anastomosis of a bridge graft, for instance, connecting the common carotid, or like in this case, the subclavian artery, to the venous system. This is a classical arteriovenous axis graft which can be used for regular hemodialysis. In patients with higher operative risk, in whom I do not want to perform median sternotomy, I have to think about alternatives. This is a patient who came to me with complete occlusion of his inferior vena cava with his insufficient recanalization following some months of bilateral femoral catheter access. Unfortunately, in former times, he also had catheter accesses via both his subclavian and internal jugular veins, so that both innominate veins and the central port of the vena cava could not be pacified and were chronically occluded. So in this case, I considered implanting an arterial interposition loop between the divided ends of the axillary artery here. This is the postoperative MR 3D reconstruction with the graft here in loop configuration. These arterial loop grafts do perform rather well for hemodialysis. They may transport between 250 and 350 mils per minute, which is just enough for sufficient hemodialysis therapy, especially if the patient is not too adipose. During the last 15 years, I operated on 42 patients with functioning excesses. In almost two-thirds, interventional treatment was possible. Venous bypass or venocaval bypass surgery was performed in only a minority of patients, while almost 1/5 required ligation and construction of another axis. Complications following PTA and stent implantation are frequent. The most frequent complication, of course, is restenosis. Almost 1/3 got these restenoses, which could, in most of the cases, be redilated. Misplacement occurred in only a single patient, which could be corrected by implanting of a second stent. Dislocation is infrequent, but may occur if a rather stiff stent is implanted into a very short stenosis. So at the moment, I prefer self-expanding flexible stents. With such a stent, I never saw any stent dislocation post-implantation. Next. Complications following veno-venous bypass surgery included one death, which was not really related to the surgical procedure, but to an antibiotic-induced Lyell syndrome with multi-organ failure and death after 6 weeks. Restenosis and reocclusions could be treated by interventional means, like in this patient who had this axillary vein to internal jugular vein bypass and the stenosis at the distal anastomosis after 4 months, which could be recanalized and stented successfully. When we look into the literature, we get the impression that PTA alone does not produce so favorable results as far as primary patency rates after 1 and 2 years is concerned. However, with repeat interventions, 1 and 2 year secondary patency rates are satisfactory. PTA with primary stent implantation seems to have better outcomes in terms of primary patency after 1 and 2 years when compared to PTA alone. And of course, again, re-interventions may further improve secondary patency rates when compared to primary patency rates. Surgical series show outcomes of 80 to 100% primary patency rates and 60 to 80% 2-year primary patency rates. But please do not forget that surgical series, as far as I know, always have rather small patient numbers. Secondary patency rates seem to be convincingly better than PTA with stent implantation, but please do not forget that all these kind of surgery, in most of the cases, is major surgery, and most of our hemodialysis patients may be unfit for that kind. Next slide. So in conclusion, 2/3 of central vein obstructions in hemodialysis patients can be treated interventionally. Only when this is impossible, surgical reconstructions should be discussed. In low-risk patients, anatomical reconstructions like veno-caval or veno-atrial bypass surgery may be an option, but most of our patients should rather be treated by extra anatomical reconstruction if the internal jugular vein, for instance, is open, or by ligation and contralateral or femoral access creation. Last resort access is an arterial loop graft, which can be a valuable last resort access for some very much compromised hemodialysis patients. And of course, patency rates of interventional and surgical repair can be enhanced by regular follow-up and repeat interventions. Thank you very much for your attention.